Dear all, apologies for running a bit late, but we will start in a couple of minutes. MEP Jerković is coming with some other guests. On
Okay, distinguished guests, ladies and gentlemen, welcome. I'm very grateful for the presence of so many of you on today's meeting on cancer screening. It is a real honor for me to welcome here today members of the European and also the Croatian Parliament, the representatives of the European institutions, World Health Organization, member states, and representatives also of Croatian Public Health Institute, clinicians, patients, advocates, and journalists. I'm especially proud that today I have 30 my former students from the Faculty of Medicine, University of Rijeka here. And I am so happy because they have a possibility to see firsthand how decisions at the EU level shape their daily life and work as future clinicians and, who knows, maybe oncologists. The participation of young people is crucial, is so important for the healthy democracy. And it is important that you, young people, shape the future that you want to live. Before we get into the topic, let's just try to imagine a Europe in which citizens are regularly invited to cancer screening, a Europe in which there are no inequalities in the way how we detect and treat the disease. When we take a look at the statistics today, we realize that there is a long way ahead of us if we want to achieve that. Cancer is the second leading cause of death, and according to the European Cancer Inequality Registry, disparities seen in the implementation of the screening programs in the member states are alarming. And that's the truth. However, the scenario in which we ramp up our cancer screening rates and close the inequalities gap is not, how to say, unimaginable or inconceivable. On the contrary, it is doable. Now more than ever, with the know-how and the financial resources of the Europe's Beating Cancer Plan, which was launched 2 years ago. I have chosen cancer screening as a topic of today's meeting because as a scientist and also as a medical doctor, I truly believe that this is a very strong tool, that this is a good chance, to improve patient outcomes and poor cancer survival rates. Cancer is deadly, cancer is personal, it's a social problem, economic problem, is exhausting in all possible ways. It affects every aspect of patients' life, and it deteriorates both physical and mental well-being. It is, in fact, hard to find someone who has not been affected by this disease one way or another. Newly adopted science-based EU cancer screening recommendations should be a must for the member states, and their implementation should be a priority for their health administrations. So, without further ado, let's kick off this meeting. I hope that this meeting will be a valuable opportunity for all of us to learn, to network, and collaborate. And before we start, I invite you to hear the message from the Commissioner for the Health and Food Safety, Stella Kyriakides. As we all know, she has been fully dedicated to bringing Beating Cancer Plan to the forefront. So thank you very much, and let's hear what Commissioner Kyriakides has to say today. Thank you.
Honorable Member Jerković, dear Romana, ladies and gentlemen. As you all know, Europe's Beating Cancer Plan is a key pillar of our European Health Union and the first European cancer plan. It is our commitment to making a true difference for cancer patients, their families, carers, and for all European citizens, backed up by unprecedented investments and ambitious goals. There is a good reason for this. Cancer is one of the major health challenges of our time. To change the realities of cancer, screening is key. But access to screening differs widely, with coverage for breast cancer screening ranging from 6% to 90%, and from about 25% to 80% for cervical cancer. As the title of your event aptly puts it, it is time to screen. We have now new, forward-looking and science-based recommendations for cancer screening at EU level. With these recommendations, we want to achieve two main things. The first, to expand screening guidelines beyond breast, cervical, and colorectal cancer to cover also lung, prostate, and gastric cancer screening. To give you a sense of the importance of doing this, lung cancer is the fourth most frequently occurring cancer, but the leading cause of cancer death in the EU. In addition, prostate cancer is the most frequently occurring cancer in men. The second objective is to broaden the age ranges for breast cancer screening and update the screening tests used for breast, colorectal, and cervical cancer. With the new recommendations, we cover 6 cancer sites that totally make up more than half of all the cancer cases and of all cancer deaths in the EU. The scope for impactful change is big. Ladies and gentlemen, the successful implementation of these recommendations will depend on clinicians, on patients, on health policy professionals, and member states coming together to share their experiences and, most importantly, best practices. It will also depend on having the necessary financial resources. And we have allocated around 140 million euro to, for example, strengthen the implementation of innovative approaches to prostate, lung, and gastric cancer screening in the EU, as well as EU guidelines and quality assurance schemes, notably for breast and colorectal cancer. This is an initiative that does have the power to change the realities of cancer at EU level. I look forward to working with all of you to ensure that we deliver on our strong commitment. Thank you.
Excellent. And with these inspiring words by Commissioner Kyriakides, we will start with our first panel. Starting from my left side, I'm happy to greet Professor George Griffin, board member of the Federation of European Academies of Medicine and coordinator of the CEPEA project on cancer screening, Professor Emeritus of Infectious Diseases and Medicine at St. George's University of London, Mr. Philip Roux, Head of Unit, Cancer, Health and Non-Policies in the European Commission, Ms. Adela Magyar, Senior EU Affairs Manager in the European Cancer Patient Coalition. And online we have Dr. Gauden Galea. He is a strategic advisor to the Regional Director on NCDs and Innovation in the World Health Organization. Welcome everyone, and I just want to check if Dr. Galea can hear us.
I can hear you. Can you hear me?
Yes, excellent.
Perfect.
The title of this panel is Setting the Scene, and perhaps the best way to set the scene, indeed, is to hear more about these updated screening recommendations. Mr. Roux, I will start with you. What are the major changes introduced to the new Council recommendations on cancer screening?
Thank you very much. First of all, perhaps important to introduce myself a bit. I'm not an expert, I'm not a scientist, I'm not a medical doctor. I'm the one that should speak the less in such a panel, so that's very important. My main role is to be an honest broker, and I'm trying to put the right people together so that we achieve results, and we achieve what my commissioner explained before. So that I wanted to make that clear as an introduction, because I feel being a fraud very often when I see so knowledgeful people around me. So that, I think, was important. Having said that, I don't neglect my role in the sense we indeed as a unit are trying to make the best of what Parliament and Council agreed to put in motion, which is the Beating Action Plan, the Cancer Beating Action Plan, which is, as said by my commissioner, important for many reasons. First, because it touches an important subject matter, of course, but also because for the first time, so much was invested and so much energy has been put in one direction, so which let's hope, makes hope that we will indeed achieve results. So having said that, when we focus on the screening part of the Europe Speaking Cancer Plan, we have a cancer screening scheme which encompasses a number of initiatives. The first of which is the update of the Council recommendation on cancer screening. And just to give you an idea and a point of reference, the first version was in 2003. So the second version is 20 years after. So let's hope that if there is a need, thanks to science, for an update, that it will not take so much time, that we reconsider additional and new recommendation. So the overall goal of this new scheme in the cancer plan is that we ensure, and that's important to me to repeat it, my commissioner mentioned it, but it's we want to ensure that 90% of the target populations are being offered breast, cervical, and colorectal cancer screening by 2025. So there is really this objective to combat inequalities and to help the member states to reach that goal. I think the recommendation present a significant advance also when it comes to reflecting available tests and protocol and available scientific evidence. New tests for all 3 previously covered cancer sites, breast, colorectal, and cervical cancer, have been included. With lung, prostate, and under certain circumstances, gastric cancer, 3 new cancer sites have been included. Also requiring further research to some degree. Here the science is not always sufficient, and therefore there is a need to work more in order to have the best approach. One element for us which is also important is that the new recommendation reflects more issues which were not before in the previous version, looking at the gender inequality and the need for example, and you have mentioned that in your introduction, the importance to touch marginalized or disadvantaged populations. Persons that have disabilities, for instance, which very often have had tremendous difficulties to access to screening schemes. And they were not taken into account in the 2003 recommendations. And last, for me to mention here, the text itself pushes for more research, and we are cooperating within the Commission to ensure that indeed that there is a mission on cancer that works hand in hand with us when we support those on the ground that do the work, that also research goes and point in the same direction. So I think in that, I would say that's what's new and that's what's provide as a base these council recommendations. Thank you.
Excellent, thank you. We have Professor Griffin today with us. He worked on a project that served to make a proposal on the new cancer screening recommendations. We'll go back to that later, but I have a question for Professor Griffin now. What are the challenges and how do you perceive the reception and implementation of these recommendations in the member states? Because this is what we are talking about today, the implementation.
Well, thank you very much. It's a great honor for me to be here today to address these questions, some of which I can give very good scientific evidence for. Others are much more difficult to think about, and we've already heard of some of those already, which are sociological and to do with the worries that people have about cancer screening. I'm going to talk about the science and the clinical medicine as my part of the discussion today. And this is based, as I'll tell you later on, in scientific evidence that we gathered over a year recently and then published. The challenges for implementation are, first of all, at the clinical level, the equipment which is needed for screening. CT scanning, you will hear, is one of the modalities of screening for lung cancer, which is a great killer in Europe. But alongside of that, there has to be cessation of smoking programs. So it's not just the kit that's needed, it's the following up as well of this and the prevention of it. And you'll hear about that when I talk about cervical cancer. At the moment, there is a large EU grant with Erasmus University, and Harry de Koning, who is an expert, and I'll tell you about him later on, is looking at health inequalities within member states for cancer screening. And a lot of this comes down to the screening equipment which is needed, CT scanning and vaccination, as you'll hear, which is a separate question, hesitancy and refusal for vaccination. I'll talk about that in cervical cancer later on. There's a problem with migrants. They have no idea of the vaccinations they've received. They have no idea of any screening. And this is going to be a major problem for all EU states and all countries receiving migrants. So it's not as straightforward as we would think, but there are big steps that can be done. And I'll be talking about some of those later on. And it's multifactorial, sociological, it's equipment, it's clinical. And what do you do? What are the facilities you need if you have a positive screening test? You have to be able to do something about it. No use just screening. You have to be able to say, you need to be followed very closely, or you may need surgery. And we need to involve your family in this. So it's multifactorial would be the word I would like you to take home from this first talk.
Thank you, Professor Griffin, and challenging indeed, especially because before introducing a screening program, the member states should make sure that the program is cost-effective and that it has more benefits than harms. I will go now to Dr. Galea, because in 2022, the World Health Organization published a short guide to cancer screening, increase effectiveness, maximize benefits, and minimize harm. Mr. Galea, can you tell us how to weigh in on the benefits and harms of a cancer screening program? How do we make sure that the benefits of a program outweigh the harms?
Thank you, Lana. Also, it is a great honor for me to join this distinguished panel. And thank you to Professor Jerković for inviting me. My not being there is a handicap that I want to rail against, but I am represented on the floor by Marie-Lise Corbex, who is the coordinator of the cancer work in Europe. If you could wave so that the others can see who you are, and Maria Sotiru, who is the liaison person with the European Parliament. A great question, because it is very easy for us to focus on the benefits of cancer screening, and it's many have been mentioned already. Reduced mortality, reduced incidence, less invasive treatment if we can catch the disease early, reduced severity and morbidity. But unfortunately, it comes down to me to bring the bad news that there are also many harms that result from screening, especially screening that is inappropriately done or badly planned or badly governed, or has a poor quality control program, or is for inappropriate cancers that will not benefit from screening. So the issue of planning a cancer screening program is an issue of balancing the benefits and the harms, of analyzing who and how many people are standing to benefit, and what are the harms that might result. So it's important and maybe useful for us to go briefly into this detail here. Again, the benefits are those of earlier diagnosis. We catch the disease earlier in the natural history, earlier in its progression. We can maybe halt the disease. We may be able to offer less invasive treatment. We may aim for better overall outcomes, less severe illness, deaths that are prevented. But on the other hand, the cancer screening program is a pathway. We are inviting a apparently healthy population to come into the health system, submit to a test that may sometimes inappropriately label them as being as having a cancer. In that case, that's a false positive, or may even miss cases of cancer. That's the false negative. So people who, if we miss cancers, we may even delay the diagnosis, reduce population support for the program. We may even have legal liability. With false positives, we may lead to the complications of the test itself. We may strain the health system by providing unneeded services and investigations. And certainly with false positives, we may even inflict quite substantial psychological harm. I am, and I tell you here, a recent cancer survivor. I am alive, not necessarily because of the screening, but because I had a good access to good treatment, to good management. And therefore, as Professor Griffin has said, it's very important that we see the screening program as part of a pathway that includes the treatment. Screening alone gives people a label. After that, what do they do with that label? How do they cope with it? Therefore, the decision to screen, even the screening for cervical, breast, and colorectal, where we have best buys that are supported by all the evidence that has already been cited, even by previous speakers and Commissioner Kyriakides and my old friend and colleague Philip Roux. We need to build this balance sheet of what happens, what are the possible exit points when a person enters the screening pathway. And we must also remember that even true positives have problems, meaning even when we correctly identify a cancer, in some areas of screening or some proposed screening modalities that are outside the 6 we are discussing here, one may be able to detect a cancer early, but there is no effective treatment, or the cancer will not benefit from being treated. If I were to give you one word from my first intervention here, therefore, it is a balance sheet. We need to make sure that we have clear quantification of the benefits and the harms of the screening program. And the benefits can only be realized if we have a health system as well that has the capacity to execute appropriate management once the cancer has been identified.
Excellent. Thank you for sharing this with us. When Professor Griffin spoke, he also mentioned if there is one word as a key takeaway, that would be multifactorial. You have just mentioned balance sheet. We will see if with Ms. Magyar would have one word to put forward as well. Ms. Magyar, one of the key parts of a well-functioning screening program is reaching the population and securing the good turnout. So how can we tailor the population-based screening to respond better to individual needs?
Well, first of all, good afternoon. It's a pleasure to be here with you. And I really thank Mrs. Jerković for considering the European Cancer Patient Coalition for this event. As a background, I am a pharmacist PhD, and I'm also a patient advocate. And for those of you that don't know the European Cancer Coalition, well, we are the voice of people with cancer in Europe and beyond. We have more than 450 members in 50 countries. And our vision is for a Europe of equality, where all Europeans with cancer have timely and affordable access to the best treatment and care available. And now going back to your question, Lana, well, recently with the upcoming long-awaited pharmaceutical legislation, we get to discuss a lot here in Brussels about how to better define the unmet medical need. However, we must keep in mind that actually before becoming patients with unmet medical needs, we are all individuals that at times have unmet health needs. And timely access to screening can actually be a need as such, because for the different population groups in Europe at this moment. And we must consider also the lessons that we learned from the COVID pandemic. And therefore, I think it's time to start building value-based healthcare systems. And I think that would be my keyword for this intervention. Because only such systems can actually create incentives and investment for an investment capacity for high value intervention and innovation that can actually improve the patient and population health outcomes in the long term, and including here through primary and secondary prevention. And I truly believe that only a value-based healthcare system can actually understand and monitor the actual needs, goals, values, preferences of its patients, and also embracing at the same time the shared decision-making and the co-creation of care. And the European Cancer Patient Coalition has worked last year very closely with the Czech presidency and also the Challenge Cancer Parliamentary Intergroup, where we hold the secretariat and where also Mrs. Jerković is a member. And we worked closely to ensure that patients' perspective was actually included in the revision of the Council recommendation on cancer screening. And therefore, at the beginning of November, we organized an internal meeting of the intergroup here in the Parliament to discuss the Council recommendations on lung cancer. And as a result of this meeting, we have drafted a declaration signed by 48 MEPs, and we thank again Mrs. Jerković for supporting this declaration. And we sent this declaration to the Council, calling on them to recognize the high burden of the lung cancer and take the evidence-based necessary steps to help minimize this burden through ensuring lung cancer screening and also the optimization of the care pathway. And I must say that it was kind of deceiving, a bit frustrating to see that actually the Council recommendation was not ambitious enough in considering the scientific evidence for lung cancer screening. And this is also partially the result of patients not having a stronger voice in the national context. And therefore at ECPC we do our best to provide patients with the valid and reliable information they need and we also get involved in projects and activities to support member states to invest more in health literacy and digital health literacy, and to empower patients to actually have a voice. And I will pause here.
Thank you. Indeed, value-based healthcare systems are really important, and they would also help to bridge something that it's very talked about in the past couple of months here in Brussels, and it's inequalities gap observed in the bloc. And recently, the European Commission published country cancer profiles under the European Cancer Inequalities Registry. Mr. Roux, what were the most important findings on cancer screening across the EU?
Well, let me first, one personal message, if you allow. to my friend online, because he said, indeed, he added to the fact that I'm not an expert, which I said myself, that I'm also old. So thank you for that. But it's a pleasure to see you again. That's my first personal message. The second would be for you, because indeed, you may have seen that there was a difference between the Commission proposal and the final Council recommendations. And you may have noticed that we have been somewhat more ambitious, or we wanted it to be more ambitious. So we tried that, but we have had interesting and I think a fruitful discussion in the Council that left at the end these 3 additional Council sites in the recommendations. And I think the victory, if there is one to have, is here. So these were the 2. Now, another victory to me was that indeed, even before I had the responsibility of this unit that is having a focus on cancer, I was responsible for health information, and it is in this context that we decided indeed to contribute to the action plan by having this additional tool, which is the Cancer Inequality Registry, which I always add process, because for me it's not just a registry, it's not just an online database as we have many. But what we try to conceive is something which is more dynamic, which is more useful to everyone. And how did we do that? We first decided that the Commission, as we are not the expert, I've said. Of course, there are exceptions, because we have one of our department is a GRC, so the Joint Research Center. So we have expert there. We have in DG Research researchers, so they are. I'm more a policy officer, so I'm more here in help. So this is the reason why I go that direction. And there are future experts too here in the room. So for me, the important thing to say here is that indeed we work to have a process by which we have not only the gathering of science, and not having all the science in one place, but gathering the science where it is. So we find the science where it is, and with the modern tools, we put all that accessible via the GRC. So we have indeed a sort of database, so we have one, but we have also 2 other elements in the process, one of which is the one that you have mentioned, which is the country report that we have published. And I think that for us is important, and we will have another element, which is an horizontal report that is produced every 2 years. So the idea is to have a sort of cycle by which we will have 1 year, like this year, we have country profiles, and the following year we have a global report, and the following year again a country report, and so on and so on. So the idea is to follow up. You may have seen perhaps we have done this more generally for health with the health profiles, and I think it's a good approach. The reason why is first because it is not aimed at creating competition among the member states. So it's not a name and shaming exercise. It's not either a tool to put pressure, but on the contrary, it's a tool that helps also within countries, because we are not looking at the disparities between the countries, but also within the countries. And we do not it alone. We work with GRC and with the OECD, so which means it is not a Commission standalone piece of work, but it's a piece of work that is dealt with by these 3, I would say, groups, plus stakeholders, external stakeholders, because science is not only within OECD, but also there is WHO that is involved. We have also people from IAC, from other organizations that will join, and we have a stakeholder group that we have asked to help us in following the development of it. So on the one hand with member states, and another group with the stakeholders at large. So we are really trying to develop the tool that allow to really see as close as possible of the reality. So what did he say? I hope you have had the opportunity to read them, or at least to read your national one, because and you have no excuse, because you know, I'm torturing English. It's my pleasure. I'm French. But it's also in French for France, and it's in Croatian for Croatia. It's in your language. So you can see your country profile in your language. So before comparing with other countries, it's important to compare against yourself. And so here the cycle will have certainly an important role to play, and to see whether we have been able to make the progress we hope to make. Because the first report that we have seen, they say things that you already know, and I'm just repeating what you definitely know. First of all, that they are in screening, as in other domains, many, I would say, persistent inequalities across member states, but also within member states, depending on your socioeconomic level, but also your education level, and also the regions you are living in. So depending on where you live, also your access to screening is less. So these are elements. I will not put names of countries. My colleagues prepared me notes with you can compare this country against this country. No, this is not what I want to share with you today. What I want to say is that indeed that they are a big variation. I mean, they are examples. So cervical cancer screening, for instance, there is big variation, for instance, within countries. You have mentioned, indeed, what we don't know yet, what will have been the impact of COVID also on that part. And even if I agree with what was said before by Gordon, screening alone is not enough. You need to have screening for a reason. It's to go then for treatment, for sure. But if you're not screened, it's more difficult to know that you need to be treated. And we don't know yet the impact of COVID in that, because of course COVID made it much more difficult even to go to screening. And so that it is certainly to see further. And I think that was perhaps the last element of information I wanted to say at this point, is that all the data that we have so far and that are used for the country reports dates before the pandemic. So let's see in the next edition what will have been the impact of the pandemic, and certainly it will have had a huge impact.
Thank you. I think everyone in this room will agree that the Inequalities Registry is not naming and shaming, but it is an excellent starting point. And hearing all this just confirms that the importance of implementing of these recommendations is of utmost importance. So, Mr. Galea, which steps does the Health Ministry have to take in order to start implementing a cancer screening program?
Yes, and I think these steps have already been very well implied in what has been said. And I really reinforce Philippe's point just now on we need to look at how COVID has impacted the capacity to treat, how it has delayed treatment in the case of some people. I would say, therefore, that for a screening program to be initiated in a country, we would need to have a pre-screening program, a pre-evaluation. And that is, we need to ask ourselves, how are the people who have been opportunistically identified as having a cancer, how are they being treated? What access are they getting? What survival are we recording? What is the level of mortality? What is the quality of life that they are living? How are we controlling their pain? How are we providing them with evidence-based treatment? And we need to convince ourselves this is not a debate of one or the other. We need to do screening and we need to do treatment. But everyone who's screened is going to land in a health system that is either capable of giving them good treatment or bad. Let's keep it simple. And we need to therefore focus on making sure that everyone identified is given access that is equitable, just, and effective. Then comes the importance of selecting the appropriate conditions. And we know the traditional and very important, long-established criteria on what tests, screening programs a country should adopt. We need a disease where the condition has a known natural history, a known progression, where we know that there is at least some stage in that progression that can be halted or even massively improved. We need to know that we have tests that are safe, that are affordable enough to be offered to the whole population that needs them. Tests that are acceptable and do not have themselves complications and are either non or minimally invasive. And these tests must have a good yield. The health system, I've already said, needs to have the readiness and the capacity demonstrated to treat known cancers. If there are poor quality indicators, if there are strong inequities, if there are barriers to access, then why increase the strain? Therefore, we need to be on a what our regional director calls, Dr. Hans Kluge calls this dual track approach. We need to be innovative and responding to the challenges, the modern health challenges, while also being sure that we provide the routine and the basic. So this justifies very strongly the cervix, breast, and colorectal recommendation, and justify focused on cervix, the archetypal cancer that is the best candidate, I would argue, of screening for any condition, cancer or otherwise. If a country is not well on the way to elimination of cervical cancer, which we can, it's the first cancer in history that we are able to eliminate from the global population. And if any woman is dying from cervical cancer in any country, then please think twice about doing massive expansions of the cancer screening program, because something is wrong in the system in that country. That's I would propose. Okay. We need to monitor the quality and then to consider other cancers. And I had more to say, but thank you for. Over to you, Lana.
Thank you. I think Professor Griffin has a comment.
Well, a very brief comment, which really exemplifies the common sense that we've heard from the last two speakers. In the UK, 57% of cancers present with an acute clinical presentation. That means they are presenting essentially with stage 3 and 4 of cancer. And we know in those terms, the chance of having an effective treatment is considerably reduced than if they are presenting in what are classed as stage 1 or 2. Second thing is, we had some buzzwords to remember. I'm going to give you 3 more buzzwords which are relevant to everyone in this room, whether they're politicians or medics. Do no harm. And that was taught many times to me as a medical student and then in my medical training. Do no harm. Whatever you do, always think of the patient and think that you are not harming them, you are helping them.
Thank you. I will stay with you, Professor Griffin, and I would like to go back for a moment to how it all started and the role that the Commission Scientific Advisory Mechanism played in introducing the new recommendations. So, Professor, given your involvement in the process, can you tell us about the importance of this link between policy and scientific advice? And most importantly, can you tell us something about your report, your recommendations, and are you happy with the final product? 2 minutes.
Let me tell you about the gestation. but it gives the scientific evidence for the conclusions which have been raised. And that is the crucial part of this. It is not thinking about implementation, but of course, as I said earlier on, this is very, very important, and cost effectiveness is a crucial thing to think about in the end. But without the science behind the recommendations, there cannot be good recommendations. So let me tell you how this evolved, because it was quite a gestation. And it changed during the evolution of this report. I realized as a biomedical clinical scientist that there were great advances in the diagnosis and the management of cancer. And one of those I'm going to talk about at the end in what the real advances are going to be for the future. And I suggested to the FIAM board that this was a very important topic to get scientific evidence for, and they agreed. I then had to take that idea to the Science Advice for Policy Board, which is a group of academies within Europe, for their opinion. They had to then take it to the Science Advice Mechanism in the EU and the group of chief scientists. Wow. So at the end of this, it came back. We don't want the advances. We want to have a report which looks at where we are now, and you can mention the advances. Now, this report is actually called Improving Cancer Screening in the European Union. And it talks about what is available now, what is the evidence for it, and how this can be used to the benefit of the population. Now, how did we achieve that? Well, I took it on then and found two very, very good experts. One at Erasmus University, Professor Harry de Koning, who is a global expert on cancer screening, and to Professor Rebecca Fitzgerald in the University of Cambridge, who runs the MRC cancer screening research unit. And together, with me coordinating it, we organized 3 major workshops addressing different types of cancer. 54 experts from Europe were involved in this, absolute top experts in their field. This was then reviewed by the SAM unit and by the group of chief scientists. And there was a very, very extensive literature search by a group funded by the EU in the University of Cardiff. So we were trying to cover all aspects, and we didn't want to miss any single thing out when we came up making the recommendations that we did. We had these meetings, they were all very successful, and then we had the task of bringing those together in a coherent form that was intelligible. It could be used by non-clinicians as well as clinicians. It could be used by politicians, but it could be used to make policy. And without the science behind that, it would be impossible to actually make policy. So in answer to your question, the science is the root start. And then you embed that in common sense and all of the multifactorial things that I mentioned, first of all. I will tell you what the main recommendations were, I hope, later on.
Thank you. We are running a bit late and we are slowly going towards the end of the panel. But before we conclude, the topic is cancer screening, but I would like to briefly touch upon the prevention. Ms. Magyar, one of the obstacles in ensuring not only better prevention, but also better cancer screening rates are misinformation and disinformation. So how do we improve health literacy and help reduce the exceedingly harmful consequences of misinformation that was observed during the COVID, but it also relates to the cancer screening rates.
Well, I'll try to be very short. So on my, how I see it, the misinformation is the side effect of being uninformed. And both misinformation and disinformation actually go against the progress in the society and also increase the burden of the disease. But we need to separate between two situations, namely, one is when patients receive a late cancer diagnosis because they don't have access to screening services in their area. And the second situation is when patients receive a late diagnosis because they were not aware of the services in place in their area or were misinformed about the benefits of such services. Also, it is important to mention that there is a widespread stigma towards cancer, and this stigma acts as a barrier for patients seeking diagnosis and care. And in addition, it can also contribute to a lack of empathy for people who have been diagnosed with cancer. And therefore, education and awareness raising are key in ensuring access to screening and improving the cancer outcomes at the end. And because before I mentioned the need for building value-based healthcare systems, I think that only such systems are people-centered health systems and can build on informed people and patients that actually have access to trusted sources of health information, as well as access to their health data. And we need a high level of health literacy among patients and also the healthcare professionals, and also clear communications, because only this approach can actually strengthen a health system, especially when it's confronted with a crisis like COVID. So yes, there is a need for the EU to work closely with the member states to support awareness campaigns and to ensure that EU citizens are fully informed about the availability of the cancer screening programs, and also paying a particular attention to communicate about the benefits and about the risks of these programs.
Thank you, Adela. And now finally, perhaps we can mention something as well, crucially important, which are the commercial determinants of health. And again, I would like to go back to Dr. Galea, to WHO, because the WHO has been very focused on addressing this, which is the effect that the private companies and the marketing that it has on the population's health. Can you tell us, Mr. Galea, something about the importance of governing those commercial determinants?
Thank you so much. Very fast. Commercial determinants, it's a term that's been growing in public health interest in recent terms. There are well-established examples in cancer. Obviously, the area of smoking and alcohol. We know that tobacco and all forms of alcohol, however low or high their level of consumption, they increase the risk of cancer. And yet the companies and the industries behind them in many European countries still hold back the effective regulation of price, availability, and marketing of these legal but commodities, legal but lethal commodities, as they have been called by Nicholas Freudenberg. It's less obvious to consider or to discuss what might be the private interests in the area of screening and how commercial interests might distort the balance sheet that I spoke about earlier and might produce a less systematic approach to screening. A few examples and then I will conclude. There may be low capacity for proper governance of screening in the health sector. The health sector may be very focused on what they do in the public system, but be relatively blind to activities that are happening in the private healthcare sector, where ineffective screening might be even being harmfully and wastefully offered. There might be direct-to-consumer advertising, for example, of polygenic risk scores that over the internet that suggest to people, will do your genome and will tell you if you have a risk of cancer, but there is no evidence of any benefit here. So it's just a way of increasing demand, profiting off it, but offering no, and indeed sometimes harmful screening. Physician detailing of new and unnecessary tests. For example, the pushing of thyroid cancer screening, for which there is no evidence of effectiveness. Earlier, screening tests were developed by the public sector for most of the conditions that we are talking about now, but currently, think of, for example, molecular diagnosis. Most of the new screening tests, the new waves, are coming from industry. Their evaluations are funded by industry. That reduces the rigor of the trials, and often industry captures or tries to capture key opinion leaders to set the public opinion before the scientific opinion has been finalized. And media add to this. There's media optimism. Exciting new science is more attractive, improves ratings, draws eyeballs and clicks. Consider the case, for example, of the company Theranos, how much excitement it attracted. I'm not suggesting that most companies are Theranos, but that story illustrates the way that the media attention can fog and obscure the science and impair judgment. So there's a lot here for the policymakers in Parliament, in the Commission, to consider, to regulate, and to protect the population from. Thank you.
Thank you very much. And with your answer, I will open the Q&A session, short Q&A session. So please, if any of you have any comments or questions to ask, please just raise your hand and tell us who you are and the speaker who you are referring to. Is there anyone who would like to speak? Yes? Yes.
Okay, thank you. I have a comment. My name is Joško Markić. I'm professor of pediatrics at University of Split in Croatia. First of all, I would like to thank Professor Jerković for inviting us here, because this is really nice and valuable panel. I liked what you said, that we have to work on multimodality, but what's also important to increase health literacy. And I liked when I heard that, especially the clinical appraisal of medical information, because as a pediatrician, I'm well aware of the problems we are having now and in the past with vaccination hesitancy and refusal. Unfortunately, what I heard from my fellow neonatologists, now we are also having a problem with parents refusing neonatal screening tests. I don't know in other EU countries, but in Croatia, children are screened for phenylketonuria and some other inborn errors of metabolism. And now we are also having problem with parents refusing, to take blood for those tests for their children as well. So I think this, all screening programs are great, but, besides multimodality and effective treatment, health literacy is of utmost importance, I think, for all medical future plans and implementation of any other plans, if we want to have the patients on our side. And I think that the patient groups, patient advocacy people are really have the great role in that area to increase that and to really make us, medical staff and patients to be on the same side and to work together to improve the health quality. What's important, not just to increase the surviving years, but also to improve the quality of life. Okay, thanks.
Thank you very much for your comment, Mr. Markić. Do we have any other comments or questions? We have Mr. Shekeria.
Hello, everyone. I'm Mario Shekeria. I'm the head of the Croatian National Cancer Registry and one of the representatives of Croatia in the Cancer Inequalities Group. So I have a question for Mr. Rule. In development of the Cancer Inequalities Registry, how do you see the roles of the future cancer registries in the Europe's Beating Cancer Plan with all the developments in digitalization and forms of data collection and so on?
Who's going to answer?
Mr. Rule.
Well, I think you own the answer as I do. I mean, what do we expect from the registries? I mean, first of all, what we expect is to have the as fast as possible the most updates, data and information to be able to tune the answers, because you know the main killer is the dead period between the moment we have the data is generated and the when the data is used. So on the owners of the registries at national level, what we hope from them is that they are able to deliver fast to us, and that also they work together more and more, because what we also have realized is that, and it's not only the national registry that are problematic, but registries in general. I mean, compatibility, for instance, is a huge issue. And as you well know, another ambition of the Commission is the health data space. And we hope very much to create an environment that will allow the faster availability of data. So when I said you also own the decision, the answer is not to ping pong, but on the contrary, to say that we together need to work to create the conditions for that. And one element the Commission is putting on the table is financial means. And I think you will have seen that thanks to Parliament, and we have the highest budget ever. And so we have financial means to achieve results. So thank you for that also. So I hope I have answered to your question.
Thank you.
I'm happy you are with us on the group.
Thank you. So, given that we are running a bit out of time, I would like to conclude the panel and give a word to MEP Jerković for a comment or.
Yeah, I made a lot of notes because I wanted to comment at the end, but since we are running out of time, I will just express my gratitude to all our speakers for their insights and for sharing such a valuable information with us. Nevertheless, I will comment just briefly the problem of the health literacy and prevention. Prevention, as someone said, is really a multidimensional problem, and solution to it cannot be just saying, you know, we will educate people to stop doing that and this and that. The people are under continuous, constant, subconscious marketing influence of large food, tobacco and alcohol companies. And this is, for example, the case with Croatian TV commercials for beer, especially in the time of football games. You know, when you watch the commercials at the TV, you have an impression that the beer is something like an elixir of life, you know. So let's not fool ourselves. Commercial companies have a huge impact on people's health. And therefore, along with improving the health literacy, the prevention policies should aim to govern the commercial determinants of health. Just wanted to add that. Once again, thank you so much for your contribution today.
Thank you. I will now invite our panelists to exchange the seats. So you may go, and then I'm inviting academician Samardzija, Dr. Poyo, and Dr. Ivanush to join us here.
Too long trip, not to stay.
just mingle. We couldn't. Never mind.
Professor Griffin stays. Samo on ostaje.
Sorry, what? Confused now. What are we going to do?
No, we don't have a second panel now. We're going to the second
Our
panel.
second. So I will leave the stage. If there's room, I will stay.
There is. I will just quickly make a change on the spot here because we have some panelists who are traveling later and would need to leave us a bit before 6 p.m. So instead of having, we will make a switch between the Portugal and Slovenia. We will have Professor Marta Boyo speaking second and then Dr. Ivanuš third, if that is okay with you. Excellent. So welcome, panelists. Your task today is not an easy one, so to say, because it is to show that you have done it and hopefully make others do something similar. So this panel will be a bit different. We will not have questions. We will have PowerPoint presentations. However, at the end, you will have an opportunity to pose a question to any of the speakers. So from my left side, it is really an honor to greet Professor Griffin again. Academician Miroslav Samardzija from the University of Zagreb, School of Medicine, University Hospital Center Zagreb, University Department of Respiratory Diseases, coordinator of the Croatian National Lung Cancer Screening Program. Then Dr. Urška Ivanuš from the Institute of Oncology in Ljubljana, head of the National Cervical Cancer Screening Program in Slovenia, and Dr. Marta Boyo, director of health policies in the, I don't know how to pronounce it because it is in Portuguese, but it's in English would be Cancers League, right, Marta? Oh, you're still finding your way. So let's start with academician Samardzija. Lung cancer is the fourth most frequently occurring cancer and it's the leading cause of cancer deaths in the EU. And burdened by this disease, Croatia was the first country in Europe to introduce the nationwide screening for lung cancer using low-dose CT scans. Academician Samardzija, the floor is yours.
Okay. Okay. And how can I move the slides? I will do that, but I don't know how. Okay. 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 Keep it simple. Okay. At the beginning, first, what I want to tell is I really enjoyed during the previous presentations and discussion, and I learned a lot from the previous speakers. It was a real pleasure to listen. I have to admit that. You know that speakers usually don't want to admit things like that. You also have to learn something about that, young colleagues. On behalf of Croatian colleagues, it is really a pleasure and honor to be here. Ladies and gentlemen, good evening, good afternoon to everyone, especially to distinguished parliament members, dear chair ladies and Mr. Chairman. It is a pleasure to present what we've done in Croatia. I will be very fast and briefly present and show to you first the scientific rationale for lung cancer screening, after that design and the results after 2 years of Croatian lung cancer national screening program, and of course, finally, future expectations. I hope that you will also have opportunity to see a lot of obstacles, probably pitfalls, and I think that Croatia will present how we try to cover a lot of specific difficulties which were mentioned during the previous discussions. Croatia made decision 3 years ago that we will start with lung cancer national screening program. It was completely new at that time. That is the reason why we are the first one. But it is not the problem to be the first one. You should be the wise one. That is, I think that we have to think about that. But however, Croatian program has been founded in 16 radiology centers at the beginning. At this moment, we spread and add on 4 more, which means that at this moment, we have 20 radiology centers altogether in 11 cities through whole Croatia in order to give the equal opportunity to each people and the equal access to the screening program. Can we go further? It is very easy to put on the slide the goals of the Europe Health Plan. When we see the second point, early detection, it seems it is very easy to done. But now I will tell you something from the physician's point of view. From the, let's say, 100 years, we are not used to see healthy people. We are staying in our offices, in our hospitals, and wait that sick people come to us. What is the completely different when we are talking about the early detection? We have actively searched for healthy people before the symptoms will occur. For us, that is completely new. We are not used to do that, and we have to be aware of that. Can we go further? The whole story regarding the lung cancer screening started with few scientific trials. So many times today, speakers emphasize the scientific efforts, the scientific goals, and the scientific rules. What was a real change when we are talking about the lung cancer? That was introduction of low-dose CT. Can we go further? When we introduced the low-dose CT in the screening program, please, can we move on? The next slide, please. All scientific trials showed significant mortality reduction in the range, let's say, 25%. Those advantage was even more pronounced among female, but there is don't enough, at this moment, we don't have enough scientific evidences when we are talking about the female population. Next slide, please. What is the secret of their success? It is very simple story. It is the story about the stage shift. If we introduce early detection with the low-dose CT, instead of finding disease in metastatic stage 4, we will make diagnosis in stage 1, which means when the disease is curable. This is for the first time when we start to think about the cure rate when we are talking about the lung cancer. Later you will see that is it possible to do or not. I'm pretty sure that we will show you that we can achieve that goal. Next slide, please. Inclusion criteria at this moment are more or less very similar or same everywhere in the world. We all started with high-risk population. Definition of high-risk population when we are talking about lung cancer are heavy smokers. The definition of heavy smoking means 30 pack years. This definition will change in near future, but at this moment we started with 30 pack years. At this moment, we are also talking and thinking about deprived populations. You mentioned in previous discussions. At this moment, we are also thinking about the young ladies with genetic signature, with positive family history of adenocarcinoma. There is a lot of different subgroups which will be also a part of the screening program in the very, very next future. We also mentioned the prevention. Prevention is obligatory part of lung cancer screening program in Croatia. All participants should take part in smoking cessation program. The bottom line is brochure against smoking. let's say, in that very simple way. The next slide, please. Croatian program has 5 main components. Please try to remember them, because each of these components is equally important. First, I will very briefly go through the slides and try to explain you what is going on. The first step, next slide, please, should be very precise recommendation, very precise guidelines how to analyze low dose CT. We are all talking about the low dose CT, but a few years ago, we didn't do that. We have equipment. You mentioned the problem with the equipment. Each CT can do low dose CT at this moment, but we are not used to do that. That was the first step. How we made, how we found it, how we established recommendations. Next slide, please. There is no need to remember them. You can find everything in literature on the web. These recommendations were developed together with colleagues in Mount Sinai in United States. We accepted that, made a few changes, and now they are mandatory to be used in the screening program. The main goal is to find the cancer in the range between 6 millimeters and 15 millimeters. Okay, we are talking about the millimeters. We are not talking about the metastatic disease which we usually see in everyday life. Next slide, please. For you, volumetric analysis and use of AI probably means nothing when we are talking about the low dose CT. But at this moment, we are pretty sure that volumetric analysis should be mandatory in each lung cancer screening program. That means that we will not measure just the diameter of the nodule, of the lesion. We will do 3D analysis and measure the volume. Next slide, please. Why is that important? Because we now have new thresholds. We have new cutoff values. We never use those thresholds 2 years ago. This is something completely new. Of course, in the future, probably we will change those thresholds. We will see what will happen in the very near future. Next slide, please. Why the artificial intelligence? Everyone wants to talk about that at this time. But when we are talking about the lung cancer screening, the advantages of AI are in terms of reproducibility, mobility, and equality. What that means, I will give you a very simple example. First scan can be done in Zagreb. If we all use the same recommendations, the same technical guidelines and recommendations, and if we all use the same artificial intelligence program, second follow-up scan can be done in Brussels, in United States, in United Kingdom, wherever you want. That enables mobility, okay? Next slide, please. And finally, we started at the heart of COVID time. You remember that time. Everything was locked down. That was one of the reasons why we don't want to invite participants by media or by invitation letter. And the second reason why the whole program is based on GPs, general practitioners, is the fact that from the beginning, we want to integrate cancer screening program in the regular healthcare system. Usually, screening programs are somewhere behind the regular healthcare system. That is the reason why we have special invitations. We have to do the whole program somewhere else. Some other people want to do that. Here we don't want to, let's say, we don't want to repeat that mistake, and we want full implementation, full integration in the healthcare system. Of course, there is a problem. If you want to achieve that, you need to connect all those physicians. That was the reason, next slide please, why the whole program is completely digitalized. That means that we built a digital platform which connects all GPs. In Croatia, that means 2,500 GPs. They're all connected with 20 radiology centers, and after that with 6 centers who are capable to perform additional workup and finally surgery. The second advantage of digitalization is that you can follow up the patient or participant journey. Okay? You will know what will happen with him in the future. From the same platform, you also can make control and reporting of the whole program. That was the messages and possible obstacles of the screening programs, which was mentioned during the previous presentations. So that platform, all radiologists will also give the structured report. All respiratory physicians should do that in the structured form and with very precise recommendations. Otherwise, digital platform doesn't work. You all know that from other digital platforms. Please, the next slide. Now, a few words about the results. After 2 years, 2.5 at this moment, we scanned more than 16,000 CTs. It is a huge number. All scientific projects involved or enroll significantly less participants in comparison with our national program. Don't remember all the numbers, just 2 of them. 4% of those people fulfill criteria for immediate workup. That means that they have criteria of a possible malignant disease. 4% of them. Until now, lung cancer was confirmed in approximately 1.2% of them. Next slide, please. When you have full integration in the healthcare system, it is easy to follow up the participants. It is easy to give them approach to a respiratory medicine, to a thoracic surgery. That is the reason why half of them were not eligible for the surgery, of course, due to advanced disease, but the other half underwent surgery. The half of that half, which means approximately 25%, had surgery in phase 1. That means that these 40 participants, 40 people, they are probably cured. We will know that after 5 years of follow-up, but probability they are cured is somewhere in the range between 80 and 90% for the stage 1A. That was the goal. That was the reason why we want to start with screening programs in general. Next slide, please. Whenever you discover the new land, on the horizon, you will see a lot of new challenges. Someone mentioned psychological harm. That's true. When you get a report of the screening low-dose CT, which is very sophisticated method, CT is very sophisticated tool, you will be afraid when you see a lot of negative things there. That is the reason why the huge hospital, huge centers, whoever want to really make the screening programs should think about that. That is the reason why we will establish Department of Psychology only for the purpose of the screening programs, not the general psychological department. The second thing, you should establish lung nodule clinic, because we don't have experience with the small tumors. We don't know how to deal with that. It is not possible to do that in each hospital. You need the centers. Croatia, at this moment, established 6 centers for that. It is enough for Croatia. There is no need for more. And for me, the most teasing scientific point of the screening when you use sophisticated tool is how to extend screening programs. Because on the CT, you can see the whole lung. you can see the heart, you can see the liver, you can see different organs and different diseases. Please, next slide. At this moment, I will show to you only the result for the, let's say, scientific effort to extend screening from lung cancer to another very frequent lung disease, COPD. That means in my hospital, all low-dose CT scans were analyzed in the way to make early diagnosis of COPD. If you are looking at the numbers, almost 40% of those people, of those participants, of those, let's say, healthy individuals, but heavy smokers, 40% of them have sign of emphysema. Radiology emphysema is the most frequent phenotype of COPD. Of course, we perform lung function tests to all of them. Half of them have, let's say, normal lung function. We are pretty sure at this moment that for the first time, we are talking and we are thinking about the COPD with preserved lung function. It is something completely new, but it is also very important when we are talking about the prevention, when we are talking about the early detection. And last slide, please. I hope so that I convinced you that with this program, which lasts 2.5 years at this moment, we give some kind of proof of concept. It is possible to do that on the national level, and results are more than promising. And just one thing I want to emphasize at the end, digitalization. When you have that, that means that you will have all the data at the same place. That means that at the same time, we are building the database storage. That means that in very near future, we will get automatic reporting. That is also very important. Reporting is probably the most important because without regular reporting, there is no final outcome, which means improved survival and follow-up of those people. Thanks.
Thank you very much, Academician Samardzija. We will move quickly to our next presentation.
I didn't touch nothing.
I think our technicians are handling it, or not.
Have to come down again.
Perhaps Dr. Poyo can start telling us a bit about without the PowerPoint present. Ah, here it goes. Okay. So as mentioned at the beginning, Professor Poyo, she's Director of Health Projects, Liga Portuguesa contra o Cancro, and she will present the success story of Portugal's national breast cancer screening program. In the meantime, perhaps somebody has a question for Academician Samardzija. He will have to leave earlier, though. Ah, it's here. Excellent.
Good afternoon, everyone. Thank you for this invitation. It's a pleasure for me to be here and present my institution, Liga Portuguesa contra o Cancro. I can translate this, Portuguese League Against Cancer. Next, please. So what is this association? Next, I have, next. This association is a non-governmental organization founded in 1941 and declared by law of public utility a relevant social aim. The main goal of this association is to fight cancer and support cancer patients and their families. So this organization is divided in 5 regional administrations and have more than 112 support groups. Importantly, this administration board and the coordination of these support groups are 100% voluntary. However, the size of this organization needs employees. Currently, we have more than 279 employees. Next. So the key areas of this action of this association is patient support and their caregivers, primary prevention, secondary prevention, and the training and research in oncology. Next. So we have support in hospital volunteers. Next. Self-help groups to help patients, psychology, oncology support, juridical support, social support, home support service, patient transport, and cancer support helpline. Regarding primary prevention, you have programs in health education. You can move. And also in awareness, because literacy is very important in this case, and we have a low literacy level in Portugal, and for us it's very important, this literacy. Regarding secondary prevention, we have breast cancer screening, but also others early diagnosis, not population-based programs, but opportunistic screening in skin and oral cavity cancer, because this type of cancers are a health problem in Portugal. And finally, but also important, we also support oncology research grants, but also oncology training and scholarship. And we also organize congress and training health technicians. So next. However, I'm today to talk about breast cancer screening. In Portugal, the breast cancer screening is performed by different entities, such as Liga Portuguesa contra o Cancro, that is a no-governmental organization, as I said before, but also in the red zone is performed by Oncological Association from Algarve, also an NGO, and in Iceland is performed by Regional Health Service of Azores and Regional Health Service of Madeira. However, our association, Liga Portuguesa contra o Cancro, perform breast cancer screening in 88% of national territory in the high-density population regions, in the height way. So, Liga Portuguesa contra o Cancro starts with a pilot project in 1985, then extended in whole central regions. In 1997, start in South region, then in North region. Simultaneously, Algarve region in white also start with the Oncological Association of Algarve, and then in the Azores and Madeira Islands by health governments. However, and importantly to refer, only in 2021, the entire national territory was covered in the yellow area. The yellow area involves more than 400,000 humans was included in the breast cancer screening. And only in this year, we has equity for whole population, where human in Portugal. Next, please. How we perform it with mobile unities. You have 39 mobile unities. Also in Algarve and the Islands, it's works same way. We have 90 unities in the north, 10 in the center, and 10 in the south. And we have a read and recall center in its zone in north, center, and south. Next, please. So we have more than 115 employees in this breast cancer screening, administrative health technicians and medical doctors. And inside of these unities, we have digital mammography and tomosynth mammography. The operation starts with the planning. The health service gives us the contact of the humans that we need to invite for the screening with the age that is 15 and to 69 years old. We have a plan in each year. We have an example which unity goes each region. Then we do invitation for this human. The invitation includes the criteria and the local and data and hour to participate in screening. We perform divulgation using social media, newspaper, radio to call humans, and as possible, we'll perform a last call for each woman to participate in screen. The screen is the next step. Then after screen, we go to double reading as the criteria is a goal for this screening. And then we have the result. The result could be negative and the human receive a letter with negative results, or if it was positive, woman receive a telephone call and we remark the further diagnosis assessment. This woman could be in control over 6 or 12 months, or receive a hospital refer to treatment. If was negative, start the screen again after 2 years. The most important outcomes are the human invitation. So we increase this invitation over the last 3 years because this area, yellow area, was involved, was covered, and increased 400,000 humans in this screening, which reflects the participation rate. So the first participation is low. So we have a low tax of participation rate in first time. However, over time, humans starts to participate, and our repetition participation rate is a good rate. Regarding the last data is regarding recall rate. We have a low recall rate, but also increase because the number of human for the first time also increase, and the doubts is higher in the first time of this participation. And however, the referral rate is low. We maintain the referral rate. In future, what you want, improve the participation rates because you have a new area with a lot of humans to start to participation in the screen, decrease recall rate, and we want to implement the new age groups to increase the age groups above 17 and under 15 years. Thank you for your attention.
Thank you very much. 2 very empowering presentations, I would say. It is my understanding that the 2 of our panelists have to go and catch a flight now. That would be Professor Samardzija and Dr. Poyo. So I think you will be escorted. You have 10 more minutes. Excellent. Okay. I'm not trying to push you away. Don't worry.
We will go together. Don't worry.
Excellent. And that brings us to our last presentation, and it is to Slovenia and the presentation of their success story, which is their organized population-based cervical cancer screening program called ZORA. Dr. Ivanović, I give you the floor.
Yes, thank you very much for the kind invitation. Thank you everybody for being here today. I think this is very important topic, and I'm glad that we brought it to the European Parliament also today. So next, please. Organized population-based nationwide cervical cancer screening in Slovenia started in 2003 after the decades of opportunistic screening. It is placed within the primary healthcare network of gynecologists who are smear takers, and we invite women in age group 20 to 64 every 3 years to still perform conventional pap smear. We used HPV test as a triage test and test of cure since 2011. The screening itself is comprehensive, which means that we identify women that are eligible to screening within the Central Population Registry. The Central Screening Registry is nicely synchronized with the Central Population Registry. Then we have this 3-tier invitation system. And the next step is screening, diagnostic, treatment, and follow-up after treatment if needed. All these data are registered at the Central Screening Registry for all the women, regardless the age and regardless the reason for, I would say, smear taking, diagnostic, or treatment. So we do cover also opportunistic screening, and we do monitor the quality and evaluate the results for screening and symptom for women who enter the healthcare system due to screening or due to symptoms. We put a lot of effort on monitoring in evaluation after implementing organized screening, and that is one of the reasons we believe that the results are there. We also have legal regulations for the screening program and for the screening registry. We have evidence-based national guidelines for all the steps from screening, diagnostic, treatment, follow-up, and the program is publicly funded. The establishers of the screening programs was Ministry of Health and Health Insurance Company, who nominated Institute of Oncology, where I work, as the coordinator of the screening program. We do work closely with the board of experts of different expertise involved in screening, and the Central Screening Registry is also based within the headquarters of the cervical cancer screening. Similarly are organized also breast and colorectal cancer screening programs in Slovenia. Next, please. So I will just present you 2 main results. One of them is 3-year coverage. That is the percentage of eligible women in the age of 20 to 64, which attend screening in the 3-year period. As you can see, our 3-year coverage is about 70%. That means that we reached the target that WHO and European recommendations said. And our 5-year coverage is around 85%. I was also asked to tell something about the COVID times and how it affected screening. So this is actually during the COVID times, we implemented monthly monitoring of our 3-year coverage, and each line represents the 3-year coverage from that month back. And as you can see, at the beginning of the pandemic, when the screening was closed, it was just the screening, diagnostic and treatment were continuing. Actually, our screening 3-year coverage rate fall below 70%. Immediately after the screening was reopened, after 9 weeks, we managed to increase the coverage about 70%. And then the last dip you see is the Omicron wave, and now we are going slowly up. I would like to say that we were monitoring not just the participation rate, but also the compliance to diagnostic treatment, and also treatment times were not delayed during the COVID times, regardless if the woman was detected via screening or if she was symptomatic. Next, please. And the results of the organized approach were also noticed by WHO, who put the example of Slovenia in their latest publication that was already mentioned today, A Short Guide to Cancer Screening. And actually, Slovenia makes the case how much can be done when switching from opportunistic to organized screening and implementing all the elements of organized screening, which were already mentioned today. Next, please. So it was very well known from the, I would say, data from the northern, thank you, just go forward, yes, northern countries that implemented the screening with all the elements of organized screening already in the early 60s, that the cervical cancer screening can lower the incidence of cervical cancer. And actually in the Eastern Europe, where there was some screening or not, or it was maybe the screening that was there was opportunistic, the incidence increased in the early 90s. It did not increase in northern countries, but it did increase in Slovenia. So we will similar as all other Eastern European countries with the long tradition of opportunistic screening. Next, please. The characteristic of opportunistic screening was that it was done by gynecologists every year to the women that ask for screening, or that the gynecologists think that would invite them for screening. And it was done regardless the age of the women. We didn't know anything about how many women we screen, what is the quality of screening, diagnostic follow-up, and what are the results. When we switched to organized screening in 2003, after a few years of piloting, we actually kept the same test. We prolonged the screening interval from 1 year to 3 years. We limited the age of women to 20 to 64. We managed to increase the coverage to 72% every 3 years, and now it's even better, it's 85% every 5 years. We implemented quality assurance with all the guidelines. We are monitoring closely the quality and results, and we are evaluating the screening also. We have managed to lower the recall rate. That means that women that had attended screening and had to be recalled because of something was wrong with their screening smear, from 12% to 5%. And we have managed to lower the unsatisfactory smears from 77% to less than 1%. And that is really the example how organized screening how can you do much more with much less within the organized screening. And with that, we actually managed to decrease the cervical cancer incidence to record low levels. And we are actually approaching the threshold for the cervical cancer elimination. We are not though yet there. Next, please. Next, please. We are, of course, collaborating with a lot of other countries within different projects and also otherwise. And this is such example. For example, last year we have organized within the Utopia East project a gathering of Eastern European countries that approached us with the request if they could visit Slovenia, discuss how do we screen. And we discussed about cervical, breast, colorectal cancer screening. We have also discussed how it is possible that despite the cervical cancer is the most preventable cancer, women are still dying from it. One of our partners in the Utopia East project is Romania. And the burden of cervical cancer in Romania incidence is similar to in Slovenia prior to the introduction of the screening. So there are these differences that should not be there. Next, please. And just please go till the end. Yes. So we have discussed that, of course, screening saves lives, that best benefits and harms ratio we gain with the organized approach. But screening is not easy to implement. Despite all the evidence, recommendations, and guidelines, the implementation varies greatly across the countries, and people are still dying of preventable diseases. And it's also not easy to reach the expected benefits and harms ratio in practice. We know that organized screening is best in that terms. However, due to different interests of citizens, professionals, or industry, also opportunistic screening exists. And we have heard something about opportunistic screening from WHO today already. So probably we should put more focus on the implementation of knowledge and recommendation in real-life settings. And here we usually tackle the systematic and programmatic determinants of implementation success and governance. Even though we know from the randomized trials what works and what does not, it's not easy to implement that in real-life settings where there is uncontrolled environment. Next, please. So what's the way forward? In Slovenia, we have managed to lower the incidence of cervical cancer screening almost to the threshold of elimination, with increasing quality and coverage and quality of screening within the organized approach. However, we are aware that if we are not going to increase our HPV vaccination rates and switch to HPV screening, we are not going to fall below the threshold and stay there. Next. So, of course, we are preparing for switching to HPV screening since 2017, and we want to take the advantage of the really high sensitivity of HPV test compared to cervical cytology. That also allows us to prolong the screening interval, to enable women that we are not able to call to the gynecologist to perform screening, to do self-sampling, and it is also more robust than cytology. There is less, I would say, inequalities due to different assessment of smears in different centers. Next, please. But we have found out that the timing is very important. If we switch too soon or too late, there is a high probability that opportunistic screening will spread. And we do not want that. Why? Next slide, please. And just go to the end. Despite all the benefits that HPV testing provides, there are also the limitations of HPV testing. For example, in age group of 20 to 25, as I think are some of the people I saw in this room, the prevalence of HPV in Slovenia is 25% in women. And we do not want to screen women in that age who are not vaccinated with HPV test, because we will produce the false alarms, the psychological damage. We will do diagnostic that is not necessary. We will detect lesions that could regress if not treated. And also treatment of cervical precancer can have some side effects. So we have to use HPV test-wise and within the organized program. Next, please. And only in that way, we will really reach the benefit and harms ratio and be cost effective. So we put those aims inside us, that we want to keep in the transition period the screening coverage and quality high. We want to keep screening evidence-based. We want to limit the spread of co-testing. We want to keep screening organized and limit the spread of opportunistic testing. And we want to make it acceptable by women. Because if women will think that we are taking something from them because we will prolong the screening interval, probably we will increase the starting age from 20 up, then they will search for the tests outside the organized system, which we don't want. We want to provide best for them in the system. Next, please. So what we have done, we have looked at the challenges that we face in order to keep the aims, and we found out that there are quite many of them. For example, we don't have data on colposcopy in our screening registry. Even our health insurance company does not have it. And we know that colposcopies will increase if we switch to HPV screening. We are still using conventional cytology, which does not allow for reflex testing. That means that we need to call women back. And now we just want to take one sample, liquid sample, do as many tests as possible for screening and triage if needed. We do have, it seems, very good quality of cytology. Also, the analysis shows that, and we are reaching good results. So people are asking themselves, especially cytologists and screeners who will Some of them lose their jobs. Do we really need to switch? We are doing good enough. Why do we need to switch? Do we really need to switch? And of course, there will be changes in the laboratory. People will lose jobs, people will gain jobs, and also the screening in the molecular area increase the complexity of screening. And if screening is not, if there will be too many tests, who will understand it? How will we assure compliance? And some other things. I will not go through that, but the list was long. And next, please. And when we looked actually at the principles of screening, we found out that our barriers are mostly within the programmatic and systematic part. Next, please. Next, please. Next, please. So we have decided for a stepwise approach. First, we will address implementation challenges in the first phase, and second, we will do the pilot and then roll out. Next, please. These were the actions we took in the first phase. We were educating and engaging screening providers and decision makers, trying to get a shared vision and support to HPV screening. And just last year, we achieved 80% of support toward the switching to HPV among the screening providers. We have renewed the screening registry. We are integrating it into the national EHAD. We are adding data on colposcopy, destructive treatment, HPV vaccination. We are actually regulating colposcopy and standardizing it. We are introducing the multidisciplinary management of women with cervical precancer because we do not want to treat lesions that will regress. And we have taught all our screening cytologists to read liquid-based. Next, please. And we have also done some simulation and mathematical exercise. Within the Utopia, this is the Horizon 2020 project, we have actually made the mathematical model of Slovenian cancer screening program within their MISCAN models, and for the breast, cervical, and colorectal cancer screening. And we have used the Slovenian cervical model for simulation of more than 900 HPV screening protocols to find out which is most effective. And the most effective was 5 years HPV screening from 30 to 65, which would mean that we should go to our women, to our gynecologists, to our clinicians, and says we will just move the starting age from 20 to 30, and we will prolong the interval from 3 to 5 years. We had huge resistance when we prolonged the interval from 1 year to 3 years, 20 years ago. And 3 months ago, I was still answering the letter our ministry received from Initiative of Women that we had to go back to 1 year because we are taking something from women. This is something probably our women and also clinicians will not accept. So what we asked, what we did with this exercise, we say, okay, if we think this will not be acceptable and will produce opportunistic screening, if we only take scenarios that we think are acceptable. And actually, we drew the second frontier, and to our surprise, the acceptable screening scenario, which started at 25, first with cytology and then with HPV, was the cost effectiveness was the same. But because we think it would produce more opportunistic screening, we think in practice, it would probably even better. We also did a large randomized trial of non-responders. We offered them self-sampling in opt-out and opt-in approach, so we know how it works, and we will probably implement it in non-responders. Next, please. So we are slowly moving to the second phase. We are planning the pilot project, hopefully also with the help of the EU funds. And we are preparing the HPV communication strategy also within the PERCH Joint Action Program. We have targeted for the year 23 because this year our first vaccinated cohorts will reach the age of 25. The project of the first phase reached maturity, and yes, we will publicly announce that on our 20th university, which we will celebrate on the 17th of November 2003. Next, please. And next, please. All this is written in our National Cancer Control Plan, which was also approved by the Parliament. Next, please. And that's all.
Thank you very much. Presentations of these three countries really show that increasing cancer screening rates is feasible. I will now just open our Q&A session. I ask you to keep it short. Is there anyone who... Yes.
A question about the lung cancer screening. We know that there are still a lot of questions to be answered about lung cancer screening, notably about the arms. And we also know that it's very different to screen in real life compared to randomized control trials. So I was wondering how your program will contribute to this research, if you measure overdiagnosis, if you measure false negative in collaboration with the registry, if you measure sensitivity and reproducibility among people who read the CT scan. I think there is a lot to learn from implementation in real life and how it really works on the ground. Thank you.
It was very long-lasting question, I have to admit, but I will give you a very short answer. I will remind you on volumetric analysis and artificial intelligence, why it is obligatory, especially in the way if you want to reduce the rate of false positive and false negative CT scans. If you remember our data, in fact, we didn't have false positive at all. Yeah, but we can discuss, is it a small number of participants? I think it is not. I think it is the value of volume analysis and AI. That is how we translate, tried to translate science into the real practice. Probably there are better ways, but at this moment, I don't know the better way. And I'm also pretty sure that in next few years, we will collect approximately something around 40,000 CT scans. At that time, we will do the machine learning. I'm pretty sure in that. And after that, probably we will change the new thresholds. At this moment, it is early, it is impossible to give a better comment. I don't know. I hope you agree with that.
Thank you. Yes, I was speaking more about false negative. I think it's something we really need also to measure in this lung screening program, not false positive.
Sorry, I didn't listen. I didn't hear you.
No, I'm anxious about false negative. And that's more difficult to measure, by the way. That's why
I understand. That is the reason why I mentioned the big machine learning after a few years. At this moment, to make proper interpretation of the level of false negative, you need a follow-up, okay? 2 years is not enough. At this moment, 80% of all participants just made the baseline, the first one scan, only 20% follow-up after 1 year. If you are looking at the scientific curves and the separation between low dose and no low dose scan at all, you can expect the clear difference after 4 or 5 years. Yeah, it is impossible to give the answer at this moment.
Thank you. Anyone else, maybe?
My name is Evelyn Avdic, and I'm from the Faculty of Medicine in Rijeka. I don't have a question. I just want to say thank you to all the speakers and especially to Professor Jerković in the name of all of us here for welcoming us and for giving us this special opportunity to sit here and to listen to this very special topic. And I believe it has been a great honor for all of us. And it has really given me, and I believe everyone else, the motivation to continue studying and learning so that we can maybe one day have impact on the subject important like this. So thank you again.
Thank you. And I think we have...
Okay, I would like to just thank you for this great panel. And I'm Professor Verdeljak, surgical oncologist, head of the Department of Surgical Oncology in Croatian Medical Institute for Tumors. I would like to actually, in Croatia, the picture of oncology is like this, and we have a quite good results in breast cancer treatment. Colorectal is terrible. Screening for breast cancer is pretty good, almost very like what you showed us. Colorectal is very bad, but I want to ask Professor Margia, now it's a great program that you have for screening for lung cancer. And just try to explain to the audience, we have a fantastic improvement of diagnostics in the last few years. And pretty soon, with artificial intelligence and everything we have in these CTs and MRIs and PET MRIs and PET CTs, once you find the tumor 5 millimeter, I know you'll see it and you'll say, yeah, that's a cancer. But you cannot prove it. You cannot diagnose it with cytology. You cannot diagnose it under CT. What are you going to tell to this patient? And you are sure that's a cancer.
Yeah, that is the reason why we started with 6.5 instead of 5.0. I'm kidding, of course. That is the second reason why we think that volumetric analysis is mandatory, because for two reasons. We will just not measure just the volume. What we are measuring after 3, 6, or 1 year, it depends on a few factors which are all described in our recommendations. We are measuring the volume doubling time. We are looking for a growth of cancer. Okay, it is impossible to make diagnosis or to confirm our suspicions on the malignant disease when you have really small lesions, but you can measure the growing time. At this moment, we are pretty sure there is no rush when the growing time is less than 400 days. There is no need to be in upset situation from both sides, as well as the patient, as the physician. Of course, at this moment, it is possible to make puncture of the lesions of 6, 7, or 8 millimeters. It is possible. We do that. Things change very fast. Just last minute from myself. I don't want to be the only one who is talking here. But 4 years ago, I knew nothing about the screening. I even didn't think about that at the time. Now I'm a great fan, not because I'm a part of this. The reason is that technology changed, our procedure changed, and at this moment I'm completely aware that all screening programs, the whole idea of early detection should be should be a part of healthcare system in general. We should integrate that. That is probably the most important, what I learned from the past 4 years.
Thank you very much. And I will now give the floor to MEP Jerković to give you concluding remarks.
Thank you, Lana. When I was organizing this meeting, I felt that exchange of good practices is the key. But somehow I have also impression that we are not collaborating enough in order to share the knowledge and the experiences. So this was really, for me, extremely glad to be here and to have a possibility to hear all these panelists. I learned a lot, as academician Samarjia said before. I learned a lot too, and I hope you learned from their presentations a lot. But you know, when I was entering into politics, my drive was to help people. And my father was a mayor, And I remember the mayor of the Korčula, can you imagine? And I remember him coming back from work. Sometimes he was sad and quiet, sometimes he was angry, sometimes he was happy, you know. And once I asked him, why you are smiling, why you are so happy? And he told me, today I realized that the program that my team and myself was working on for a long time finally gave a result. And that's why I'm happy. And in that time, and I was a young girl, I realized that the politics has enormous, enormous power, you know, to make good things, to make changes, to give hope, to make people's life better. And sometimes we are rewarded with seeing immediate results of our actions, but sometimes, and this is often the case, it takes a little bit longer. So rewarded are not coming always when we are expecting them or deserving them, but finally they will arrive. And each and every one of us count. We all have power to make changes. Last night I was talking with my students, and I told them that medical vocation means devoting their life to helping other people. And politics go hand in hand with that, because the key goal of the politics is to create a better society. Both callings are about making a difference in this world and making it a better place, step by step. So our discussion alone will not make all the member states rethink their approach to cancer screening and start implementing the latest scientific advice. But let's send the message that together we can make a change, because we have tools and financial resources on our disposal at this very moment. However, each of us here in this room has a role to play, I would say. I see representatives of the European institutions, the World Health Organizations, the health attaches from the member states, policy advisors, patients, clinicians, journalists, and future clinicians from Rijeka. Everyone sitting in this room has an opportunity to do at least one thing after this meeting that will help raise awareness about the need to implement the new EU cancer screening recommendations, and that it is really a time to screen. As Commissioner Kyriakides said in her video message before, scope for impactful change is big. So I think we should not miss on that opportunity. So, dear all, thank you once again for coming and for contributing to our discussions. Thanks you indeed to all of you from the bottom of my heart. Thank you.